Hello, thank you both for being here. I appreciate you being here on a Friday afternoon at 12:30. That's next door. All right, I'm Kate Bonney. I am an assistant professor of emergency medicine at the University of New Mexico. I have no financial disclosures related to this topic or other topics. So what I'm going to do in the next 20 minutes is spend a little bit of time talking about terminology for this topic of anti-fat bias, so that we're on the same page about terminology as we go through this. Then I'll go over 10 myths about anti-fat bias and provide some resources if you want to learn more about this. Our objectives are to discuss the relationship between body weight and health outcomes, to understand the history and the limitations of the body mass index, and to describe how anti-fat bias prevents patients from obtaining the health care they need. So first, a little talk about terminology here. These terms that we use to describe patients' body weight tend to have a lot of connotations, either positive or negative. So in learning about this topic, I've learned that many people in the fat community actually consider fat to be a neutral descriptor of body size that is not inherently a negative slur to be applied to people. In our society in the US, we often use fat as a term that is associated with moral failing or slovenliness or greed, and people in the fat activist community prefer that this term be used to describe someone's body weight, fat or thin, like tall or short. The terms obese and overweight are derived essentially from the body mass index, and they are used to describe body sizes that have to do with particular health outcomes. Many people in the fat activist community don't prefer these terms be used because they have implicit in them judgments about a person's health. And also the word obese comes from a Latin word which means to eat oneself fat, which is not related to many people who have extra body weight. As a healthcare professional, it's difficult for me to transition my speech to call everyone fat when I'm talking about extra body weight, so I'm going to use these terms a bit interchangeably through this talk, with the knowledge that fat is not necessarily a derogatory term in this population. So first we'll talk about some myths about anti-fat bias in medicine. Our first myth is that, like most biases, anti-fat bias is getting better. I think many of us are familiar with the implicit bias tests that come through Harvard, and these tests have been trended over years, and we can see how implicit biases are changing. Over the last decade or last couple of decades, we've seen that there is less bias towards age, gender, skin color, and perceived ethnicity. However, we've seen that anti-fat bias has actually increased a significant amount, and this is the numbers for 2007 to 2016. They are currently working on the numbers from 2016 to 2020, and we know that it definitely has not gotten better, that we are improving our bias towards neutrality in many of these ways that we see people, but anti-fat bias is getting worse. This is among the general population. This is not specifically for healthcare providers. So I think many people would say, well, people who work in the healthcare field don't have this bias. And that's our next myth. We think that physicians are going to treat fat patients equitably and not take body size into account when they are caring for their patients. So this first study was a study of healthcare providers who work in weight loss and weight centers. So the majority of these respondents were actually nutritionists and psychologists. There were some physicians in this also. But this study found that people whose sole job is to help and care for patients with extra body weight, that over half of them had negative biases against these patients. So we might say, what happens to medical students and physicians? We know that during medical school, medical students' implicit bias against fat patients decreases, but their explicit bias actually increases. And this comes directly from the modeling they see from their residents and from their attendings. I was just talking about this with a friend yesterday, and we both can recall instances where we heard attendings or residents at our respective medical schools refer to patients in Ohio units or Mississippi units or Worcester units, with each unit being a 250-pound of body weight. So we see this behavior modeled, we think it's acceptable, and we increase our explicit bias as we go through medical school. So the next myth, we talk about, well, BMI is useful because it is a proxy for a patient's health, right? We think that BMI is an objective measure. You get a BMI, it's an objective way to measure whether this patient's body weight is affecting their health. However, I think a lot of us know that the BMI is not a great measure of a person's body composition or of their health. And we know this by looking at professional athletes. Ilona Maher is a professional rugby player with a BMI of 28.7, so she's overweight according to the BMI. And Ezekiel Elliott, who is a running back in the NFL, has a BMI of 30.6, so he therefore has class 1 obesity. And I think we know that those health risks that we associate with those classifications probably don't apply to these people and probably don't apply to a lot of our patients. I think it's helpful to know where the BMI comes from when we're considering how we apply it to our patient population. So the BMI is derived from something called Correlates index that was developed in 1835 by a Belgian anthropometrist who was named Albert Quetelet. And he was interested in anthropometry, which is the study of humans, and his idea was to find l'homme moyen, which means the median or the average man. And he looked at data sets from military conscripts of French and Scottish men, so this was all European white men, looked at their measurements of their height and weight, and came up with his index. And his argument was that the average man was the perfect man, and any individual who deviated from that was imperfect. As you can imagine, this research found its way into some eugenics later on and also some issues with race. However, this index then became the body mass index and has been used for decades now to describe the relationship between height and weight in a patient, and categories of that have been used to describe health risk categories. There are some controversies that are innate within the BMI. So for instance, if it was meant to describe a population, not an individual, but we use it to describe individuals and screen them for health risks. And also, the average necessarily is going to move over time. We know that our population in the United States is becoming larger in body size, but that average stays the same, and these categories have been adjusted through that time. For instance, in 1998, the BMI categories were changed in the United States, and overnight, millions of people became overweight who had not been overweight before that time, just because of the way that the cutoffs were listed. And when we look at the relationship between predicting body composition and BMI, it's a very poor measure. So this was a study of reproductive age women, and it showed that if you look at their actual body composition and their body mass index, only 50% of the time, so a coin toss, did the BMI accurately predict whether those patients had extra body fat. And this works particularly poorly in populations like Hispanic populations, Asian populations, and Black populations. So I like this quote from a review of the use of the body mass index. This writer says that the topic is extremely complex. We're still discovering the causes of obesity, and it's still not clear whether obesity is an exposure or an outcome. Are people overweight, obese, or fat because they have conditions that lead to that, or is their health adversely affected because of their extra body weight? One way we can think of this is the myth that thinner is always healthier. I think a lot of us also know this innately. We know that being too thin is unhealthy and risky, yet our society continually tells people to lose weight and become as thin as possible. And we know that when we look at mortality curves related to body weight. So this is a study of 3.6 million adults in the United Kingdom, so I think fairly applicable to the United States. The top row is the mortality curves based on BMI for all participants, and the bottom row is for only the patients who have never smoked, so trying to remove smoking as a confounder. And this looks at all-cause mortality, communicable diseases, non-communicable diseases, and injuries and trauma. You see a pointer there? No. So if we look at this, we see that it is just as unhealthy to be underweight as it is to be overweight for a large stretch of the mortality curves here. And there are definitely many more patients who are alive and surviving at those higher BMIs than there are at the very low BMIs, because a very low BMI is incompatible with life. So for instance, the bottom end of the range here on the x-axis is a BMI of 10. I'm 5'4", I'm the average American woman height. In order to have a BMI of 10, I would have to weigh 58 pounds, which I think would probably be incompatible with life. And we can also see that extra body weight may be protective against some causes of death, and we know that especially in older populations, having some extra body weight is protective against falls, fractures, the deaths that come from those, and trauma, and that it's sort of the padding thing. Older people who are thinner and have less extra body fat are more prone to die of trauma and injuries. So I think we just need to remember that it's possible to be fat and healthy. There's an area here where people have an overweight or obese BMI, and their mortality is actually lower than patients with a very low BMI. So we need to know that you can be fat and you can be healthy. Our next myth is that body size is completely within an individual control and that being fat is a personal moral failing. I think we all know that extra body weight, fat, and obesity are increasing in this country, and that things that increase at this high rate to this number of people are usually attributable to societal factors, healthcare. We know that things like access to healthy food, work hours, walkable communities all factor into body weight and body size. Yet when we look at the individual patient, we often say it is your fault that you have extra body weight. We also know that there's a wide range of this estimate, but obesity and overweight are heritable. There are many conditions and many genes associated with overweight and obesity, and the heritability may be between 40 and 77%. So there may be much of this that is outside of the control of the individual in determining their own body weight. We know that there are many, many causes that lead to overweight and obesity, and there are at least 59 recognized types of obesity. And we also know that dieting really doesn't work. When we tell patients to diet to lose weight, they're really not being set up for success. After a year on a diet, 35% of patients have gained 5 pounds, 60% are able to maintain their weight, and sorry, I should say that only about 10% continue to lose weight. And more than half of all the weight that's lost when people are on diets is regained within 2 years after the diet is stopped. And by year 5 after stopping a diet, more than 80% of all the weight lost in diets is regained. We also know that dieting is a predictor of future weight gain. People who have tried to diet in the past are more likely to gain weight in the future. And that leads to the myth that if fat people got thin, they would be healthier. We just say if you're fat, if you lose that weight and go into a lower BMI class, you're going to be healthy. We actually know that weight cycling, which is the term for yo-yo dieting, is associated with increased health risks, so risk of cardiovascular disease, hypertension, mortality from all causes. It may be healthier for a patient who is slightly overweight according to the BMI to maintain that weight than to try to diet and continue to yo-yo diet and put themselves at risk of these adverse effects. We also know that prolonged severe dieting is very unhealthy for the metabolism. There is a fairly well-known study of participants on The Biggest Loser looking at their metabolism and diet 6 years after the competition. This showed that their metabolism slowed radically during the competition and didn't recover in the following 6 years. There were participants who 6 years after the competition, they had to eat 500 to 800 fewer calories per day to maintain their new weight than people of similar size who were to maintain their weight. Our next myth is that fat people are going to avoid healthcare because they don't like hearing the truth, that they don't want the hard love that we are going to give them to tell them to lose weight. In fact, we know from a scoping review of qualitative research that people who have extra weight or are fat or overweight have poor experiences with encountering healthcare, and things that they have noted are that they find healthcare providers contemptuous, patronizing, disrespectful, that their healthcare providers have lack of training about treating their body size, that they expect to get differential healthcare treatment compared to standard size patients, that they have low trust with their healthcare providers, they know that they have poor communication, and they may avoid or delay healthcare services because of this, and they may doctor shop to find a physician who is better at communicating with them. So those are the reasons they're avoiding healthcare. And so the related myth is that we think fat people need tough love to get thin and healthy. And I would argue that any patient who's overweight or obese, that this is not news that you're going to be telling them if you tell them that they are overweight or obese. This is probably someone who has been dieting their entire life, who knows the calorie count of every food in front of them, has tried every fad diet, and they probably are not going to be shocked by the news that you tell them that you think that they have extra body weight. We know that many of the diets we recommend have adverse effects and they may not help them in the long run, so scaring them into weight loss is really not going to be effective for their mental or physical health. Our next myth is that we shouldn't take body size into account at all when caring for our patients. We say we're just going to be blind to their body weight, we're just going to treat them exactly like anyone else. So one thing that fat patients bring up is that they may have trouble finding a chair to sit in the doctor's office. They may be told that a scale doesn't fit them, that they can't get an MRI or a CAT scan. And we need to make sure that we are creating a built environment that meets the needs of our patients. I think about a lot the analogy of the geriatric population in the United States. This is a population that is expanding in numbers. These patients have special needs. It's not a moral failing that they are getting older and may need quiet environments, special beds, special units. And there are places that are building special geriatric emergency departments. But when you talk to many providers about meeting the physical needs of obese or overweight patients, they'll say, oh, this isn't something that we want to accommodate, and they'll put it back on the patient's fault for not being able to fit the physical environment that we already have available. And we also need to take into account that there is a lot of social stigma and a lot of stress that comes from living in a fat body, and this can lead to very adverse health outcomes, whether that comes from just the chronic stress of hearing insults and being discriminated against, the stress of not being able to access health care or avoiding health care because of the attitude you're afraid you're going to encounter there. These can all lead to these patients having worse health outcomes in cardiovascular, mental health, all sorts of other conditions. So our last myth is that there's nothing I can do to help improve care for my fat patients. There are plenty of things we can do. So first, we want to recognize that fat bias is the norm and not the exception. This is what patients who are overweight and obese are telling us they experience in healthcare. I have talked to colleagues who've said, no, I don't believe that that happens, but we need to believe the lived experiences of these patients and recognize that this affects their encounter with healthcare. We need to understand that being fat has complex causes and is not an individual moral failing, that we are not there to punish a patient for their body when they come to us for help. We need to understand that the relationship between fat and health is complicated. It's possible for someone to run every day, eat a healthy diet, not smoke, and still have extra body weight. And it's also possible for someone to be thin and not do any of those positive health behaviors. And we can't tell just by looking at a patient's body size what their health is going to be. We need to remember that BMI is a screening tool and not a marker of disease. Someone with a high BMI, you may want to test them for metabolic syndrome, diabetes, hypertension, but if you find that they are healthy and have normal markers and normal vital signs, accept that as their actual health. And make sure you treat your patient and not their body weight. Treat them as a full human. We want to make medical spaces accessible, and we want to make sure that we're modeling behavior for learners, that we're not making those disparaging comments about overweight and obese patients that medical students are taking to heart and adopting as part of their practice. And then we need to study anti-fat bias in emergency medicine. There's very, very little research on this. One study I found actually shows that patients who are overweight or obese have shorter wait times in the emergency department, so maybe we're actually doing a better job than other specialties, or maybe we perceive those patients as being sicker at baseline when they may not actually be, but I think we need to look more at how we are approaching and treating these patients in our specialty. And last of all, make sure that we see these patients as humans, that their body size does not make them less than human or less deserving of our compassion and care. If you want to learn more about this topic, there's a very good podcast called Maintenance Phase that is about a lot of health topics, including overweight, obese, and fat topics. One of the co-hosts of this podcast has written 2 books, What We Don't Talk About When We Talk About Fat and You Just Need to Lose Weight, which are very good. There are also some very good books on the relationship between race and body size and fat, which I didn't go into a whole lot here, but Fearing the Black Body and Belly of the Beast are very, very good and get very much into why we negatively perceive larger bodies in our society and how that's related to race. And then if you want to assess your own bias, you can take the implicit bias test on body size from Project Implicit. There's also an attitudes towards obese persons scale and a fat phobia scale. And these are all available online. And I have a lot of references, which I'm happy to send you if you would like. Thank you. Happy to take questions. Or we can all just leave.
So I'm curious, like a lot of times, you don't want to make it all about someone's weight, right?
Mm-hmm.
They're having a conversation about something. Sometimes it's relevant, sometimes it's not.
Right.
But if it is relevant to a conversation you're having in a healthcare setting, and this might be more applicable for primary care, or maybe some surgical specialties where they're talking about like operative risk or various things, like, as you said, the patients know.
Right.
How do they, like, did you learn anything about like how they want you to approach it, like in terms of things to not say, or just like be very matter of fact about it, or like what?
I think it's going to be very individual. A lot of my learning has come from fat activists who are very much, I am a fat person and I acknowledge that. I don't think that's a universal approach to this, so I think it's going to be like any sensitive topic to sort of figure out where your patient is and talking about that and meet them where they are. I know that's not a straightforward answer, but but a lot of the literature from fat activists is very much, this is who I am, this is my identity, I want you to acknowledge it. In my personal experience with patients, I don't think everyone is quite at that end of the spectrum. All right. Yes?
I'm trying to figure out how to put my words together, but it seems a little appalling to me the way that the BMI is used in medicine, given its lack of an evidence base. And I'm just wondering, like, how it got here. How did we end up here in this place?
It came through, so the BMI really came into prominence when it was started being used in life insurance tables. MetLife, or whatever the precursor to MetLife insurance was, used these and would charge higher premiums for people with higher BMIs. The BMI then sort of made its way into medicine. It was tested against other things like caliper testing and the test where you dunk somebody in water and figure out what their body composition is. And the BMI is much easier to test than those and somewhat correlated with those results, and then was adopted by the CDC and the WHO, who drew some conclusions with health risks, but it was always meant as a population level measure, and it became this individual measure that we use sort of just through the drift of our culture in medicine.
I remember being a young woman, and I've always played sports and been really athletic, and reached this point where I'm like, well, according to this thing, I'm overweight.
Yep. And I think we all know those examples, but then somehow in our medical training we come to see BMI as a health proxy when it's really not.
Well, it's so interesting too, because like now there's these like smart scales, right? Like I got one, and you don't need calipers, you don't need the dunk, and I mean it's probably not quite as accurate, right? But like you just stand on the scale and you pull the points, and it'll give you your weight, but it gives you like this is your percent body fat, this is how much muscle mass you have, this is like the thing. It's really interesting. It'll give you like visceral fat, which we know is like correlated with some poor health outcomes and things like that. And so I feel like that would be such a better way to track. And it's not like it would be like you can get them for like $50 on Amazon.
Yeah.
It's not that hard.
Yeah, that would be great.
I don't know if this happens with you all, but I'm attending at UC Davis in Sacramento, and they have Epic. And
I wish we had Epic, but
we have Cerner.
we have Cerner.
Okay.
I'm an Epic fan.
I'll do my notes and I'll send them off, and then the billing people look over them, and then sometimes I'll get them kicked back to me. Someone will come in with something completely unrelated to their body size, and I'll get this feedback from the billers that say, and this is at the end of every note, like this person is documented as having obese, as being obese via their BMI. Was that related to the visit at all in the emergency department? And I have to say yes or no.
I've never worked anywhere where the coders ask me that.
Yeah,
That's
this is
strange.
only in the last probably year or two, so I don't know if there was a change of some sort, and I have no idea why I'm being asked that, but most of the time it has nothing to do. So I say no. I don't know if we get to.
That's really interesting.
It must be like they're adding an additional
Yeah.
diagnosis code.
Yeah.
Or something.
Yeah, we just get more money if we say that people's obesity had something to do with why they were in the front or something.
That's really interesting.
That sounds like they're creating a good data set for you to do some research from.
Thanks for your time.
Yeah, thanks for coming.
Tough time to have a talk.